Welcome back to Diabetic Files, where we look beyond the wound and into the science of nerve circulation and the decisions that ultimately determine whether a limb is preserved or saved, and that's what we want. So today, we're going to go into something that seems simple as first, but the neurological examination of the diabetic foot. We're going to go into the reflexes, the tuning fork, the monofilament, the proprioception, the pain and temperature, and the classic phrase that we hear all the time, the stocking and glove neuropathy. But what do all these things mean? And what exactly is happening inside the nervous system when somebody develops diabetic neuropathy? And why does the Achilles reflex disappear? Why does someone lose vibration? Why can someone have excruciating burning pain at the same time not feel a diabetic ulcer forming underneath their foot? And most importantly, what can podiatry do about it? Because we love podiatry here. But because diabetic neuropathy is not simple, okay? We all know that. It's not a simple thing as just saying, oh, the patient's foot is numb, right? It's about losing the nervous system ability to communicate with the foot. And when that warning system goes silent, a small injury becomes a big problem. So let's get into the basics. What exactly is a reflex, right? When a clinician takes a reflex hammer and taps a tendon, you're seeing one of the nervous system's fastest responses, a reflex. A reflex is an automatic neurological response to a stimulus, right? Think about the reflex arc. That's going to give me PTSD, but a stimulus occurs, a sensory receptor detects it, sensory nerve carries that information towards your spinal cord, and the spinal cord processes the signal, and a motor nerve then sends the response back, and the muscle contracts. Okay, so it happens incredibly quickly, right? The brain doesn't even have the chance to consciously say, okay, now contract that muscle, right? The spinal cord can coordinate that response automatically, and that's what makes reflexes so clinically useful, because when we test a reflex, we're simply not just checking whether the muscle moves or not. We're also checking whether it's getting the information about the integrity of the entire neurological pathway. So, what does diabetes do to this actual nervous system? So, let's get down to nitty gritty why we're on diabetic foot files in the first place, right? So, diabetic peripheral neuropathy is generally a length dependent distal symmetric polyneuropathy. So, that sounds quite complicated, but I'll break it down. So, length dependent means that the longest nerves are affected first. And where are the longest nerves? Those are the ones that are traveling all the way down to your feet. Think about the nerves traveling from the lower spine down the leg and to your toes. And this is a very long neurological pathway. And over time, the metabolic and vascular abnormalities associated with diabetes can damage the system. And that involves much more than simply saying high blood sugar will damage your nerves. Okay. It's much more than that. It's definitely, there's going to be oxidative stress, there's going to be mitochondrial dysfunction, there's going to be abnormalities in the glucose metabolism, there's going to be microvascular dysfunction, impaired nerve blood supply, inflammation. Remember, a lot of diabetics are in that low state of chronic inflammation, and damage to the axons and supporting cells of the nerve. And eventually, the nerve doesn't transmit information normally. And that's where the diabetic foot becomes particularly interesting, because different nerves, different fibers have different jobs. So, the nerve fibers. So, think of the nervous system as having different communication lines. Some are specialized for vibration, some are specialized for proprioception, some carry pain, some carry temperature, some control muscles. Now, some are involved in the autonomic functions such as sweating, and in diabetic neuropathy, it doesn't necessarily affect every function in the exact same way at the exact same time. So that's why we need these different tests. Now, let's start with the large fibers, okay? So, large myelinated fibers are important for things like vibration, proprioception, pressure, and certain aspects of touch. They are quite fast conducting fibers. And the myelin surrounding the nerves allows for electrical signals to travel rapidly along the axon, okay? And when the large axon enlarged fiber, functions becomes impaired, the patient may develop numbness, loss of vibration, impaired position sense, balance problems, and eventually loss of protective sensation. And this is where, one of our most important diabetic foot tests comes into play, right? With the monofilament, the tuning for reflex examination, and proprioception. That's why it's good to see the patient walk as well. And that's why I'm definitely a firm believer in ankle braces. So, yeah. So, another thing is small fibers. So small fibers include A delta and C fibers, and these are particularly important for pain, temperature, and nociception, forgive me. And this creates one of the most fascinating paradoxes when it comes to diabetic neuropathy. A patient can have the burning pain, right? They'll be like night burning pain, numbness, tingling, right? But simultaneously developing a loss of sensation. So you will hear patients say, "My feet are burning," right? But then they also say they can't feel them, really feel them, feels numb. And that sounds contradictory, right? But diabetes is like a paradox in itself, okay? But it really isn't contradictory that much, okay? So different fibers, right? Different nerve fibers can be affected differently. So a person can experience abnormal pain signals while losing that normal protective sensation. And that is one of the reasons why diabetic neuropathy is so difficult for patients to fully understand and even clinicians. So this stocking glove pattern. So let's talk about the most recognizable pattern when it comes to peripheral neuropathy. Stocking glove distribution. Why is it called that? Because the sensory loss begins distally. It starts in the toes. So and then it progresses to the forefoot and then to the foot, then to the ankle, and then higher up the leg. Eventually, the neuropathy becomes sufficiently advanced and the hands get involved, okay? So when they say stocking and glove, they mean stocking means for lower extremity and glove is for the upper extremities, right? But it's important to understand that this isn't literally a perfect anatomical stocking and glove thing, okay? The clinical description is distal symmetrical, because that's what diabetic neuropathy is symmetrical, right? Symmetrical length dependent pattern of nerve dysfunction, okay? And the longest nerves, like we said, are affected first. And that's why the feet are often where the story of the neuropathy begins. So let's talk about the Achilles reflex. Now, one of the classic reflexes that we evaluate in a diabetic foot is the Achilles tendon reflex. So the clinician gently positions the foot, taps along the Achilles tendon, and the expected response is supposed to plant a flex, okay? The reflex is primarily associated with the clinical S1 spinal level, right? And it's contributed from the S2, and that's where it gets kind of interesting. So the Achilles reflex requires an intact neurological pathway. So you need the sensory signal to travel to the spinal cord, and the spinal cord has to process that signal, and then the gastrocs and the soleus muscles have to respond. And if you have peripheral neuropathy that damages that part of the pathway, the reflex becomes reduced or absent. So, what does an absent Achilles reflex mean? So, an absent Achilles reflex does not automatically mean, oh, ta-da, the patient has diabetic neuropathy. Does not mean that, right? It's more of an important clinical distinction. Age can actually affect reflexes. Radiculopathy can affect the reflexes. Peripheral nerve disorders can affect the reflexes. Other neurological diseases can affect reflexes. So you don't just look at one reflex and say, aha, they have diabetic neuropathy, okay? Instead, we have to interpret the reflex as one piece of the neurological puzzle, and we're asking, what does this finding mean when we put it together with everything else that's occurring? So that means with the patient's history, the sensory examination, the motor examination, the monofilament, the tuning fork, the patient's symptoms, and the overall distribution of the findings. Now, the knee reflex. So the patellar reflex or the knee jerk reflex is another important reflex. So the clinician taps on the patella tendon and the normal response is extension of the knee. And that primarily is the spinal levels L2 to L4. And the femoral nerve is a major part of this pathway. And why does that matter? Because diabetic peripheral neuropathy is typically distal and length dependent. So a patient may have reduced ankle reflexes, but could have the knee reflexes remain present, right? Because it takes its time to move upwards more proximally, right? And if the pattern is unusual, for example, significant asymmetrical prominent weakness, proximal involvement, or a atypical neurological findings, we have to consider the diagnosis beyond a typical symmetrical diabetic neuropathy. Now, the tuning fork. The tuning fork, specifically the one that is 128 hertz tuning fork. You strike the fork and then you place it on a bony prominence, commonly along the great distal toe. What happens if they don't have the toe yet, the great toe anymore, right? But can you feel the vibration? And so this is more of a vibration perception test. So the vibration is largely to test the large fiber sensory function. So the patient isn't being asked, "Does this hurt?" Okay, I've once seen somebody do that. I'm like, "No, you need to see, can you feel that vibration and how long, tell me when you feel the vibration stop," things like that, right? But do you feel this vibration? That's an important distinction, okay? You're testing a different sensory modality. Now, why does vibration matter? So think about what happens when the nervous system loses the ability to detect vibration. You're losing information from the foot. You're losing that sensory information that normally travels from the foot towards the central nervous system. So the brain uses that information to understand what's happening underneath and around your foot. If the vibration perception is impaired, it's a clue that the large fiber sensory function is affected. And because diabetic neuropathy is length dependent, that means the distal foot can be an important place to detect a lot of these changes. Now, let's get to proprioception. So, proprioception is essentially your body's ability to know, like, where is my body in part of this space? Like, okay, so you close your eyes, you can move your big toe upwards, right? You don't need to look at your toe and tell it to move upwards. So, your nervous system receives information from the receptors in your muscles, your tendons, and your joints. That information helps your brain understand where your foot is within its space, right? And when proprioception is impaired, a person can develop balance problems, instability, difficulty walking in darkness, and increased fall risk. And again, large sensory fibers play an important role in this. That's why it's very important for stability, things like ankle braces, right, appropriate foot gear for diabetic patients, because doctors have talked about this. Their proprioception is affected, right? So they have lack of balance. Now, why does this matter? Because something patients immediately understand is your balance depends on several systems. Your eyes tell you what you see, your vestibular system gives your brain information about movement and the position of your head. And proprioception tells your brain, here's where my legs are, here's where the feet are. Now, imagine someone with significant peripheral neuropathy and their feet are not providing reliable sensory information. So during the day, the vision can compensate for what is happening, right? But like, what about nighttime when they're in a dark room, right? Now you're losing the visual information because it's dark. And all of a sudden, the nervous system is working with much less information about where the body is in this space. So that's one of the reasons why neuropathy can contribute to instabilities and huge fall risk. Now, the 10-gram monofilament. So the monofilament applies as a standardized pressure stimulus. So the patient closes their eyes, the clinician applies the filament according to the appropriate testing protocol, and the patient tells the clinician whether they can feel it or not. So essentially, we're asking, can you detect this pressure stimulus? If the patient cannot detect the stimulus at the appropriate sites, this can indicate what we call loss of protective sensation. This is a critical concept because the monofilament isn't simply telling us that the patient has neuropathy, it's particularly useful for identifying a patient with protective sensation impairment. And this type of foot is at increased risk of ulceration. So, the monofilament versus the tuning fork. Okay, that's an important distinction. The tuning fork asks, can you feel this vibration? The monofilament detects, can you feel this pressure?
So these two are not interchangeable. So that's why the neurological examination should not rely on just one test, okay? The ADA recommends assessing diabetic peripheral neuropathy with multiple modalities, including for vibration, proprioception, fi- reflexes, monofilament, pinprick test, and temperature. Each test will tell us something different. Now, the pinprick and temperature test. So now we're going to come back to the small fibers. So the pinprick test evaluates the patient's ability to perceive a painful stimulus. So temperature testing evaluates another sensory modality associated with the small fibers. So now we're building a neurological map. So vibration is large fibers. Proprioception is large sensory fibers. Pressure with the monofilament is a protective sensation. The pin prick is the small fiber function, help with pain. Temperature is small fiber function. Achilles reflex is the neurological reflex pathway involving the peripheral nerves and the spinal cord. And suddenly the diabetic foot examination becomes more than, oh, can you feel this? More into like an investigation neurological map, okay? So imagine the clinician examining the foot. They're not simply looking at one abnormal result. They're creating a map in their head. Where can the patient feel? Where can they not feel? Can they detect vibration? Can they identify their toe position? Can they feel pressure? Can they feel this pinprick? Can they distinguish temperature? Are the reflexes present? Are they reduced? Are they absent? Is there a pattern symmetrically or is it asymmetric? Is it distal? Is it progressing proximally? Is there a weakness? Is there a deformity? And does this pattern fit with diabetic peripheral neuropathy? So it's a bunch of detective work we have to do. So why does neuropathy create a diabetic foot problem? So we're connecting the whole neurology to limb preservation, okay? So imagine the patient steps on a piece of glass. If their nervous system is functioning normally, the pressure will occur, the pain occurs, your brain receives that signal, and immediately you move your foot, the injury gets attention, and imagine the protective sensation is perfect. So you'll be able to tell, look at the foot, ow, get it looked at immediately, right? Now, imagine that the patient's protective sensory system is damaged. The patient steps on something, the pressure occurs, but the warning signal is weak or even absent. So the person keeps on walking. They continue with their day, the next day, and they continue with the very next day. And the injury becomes pretty much exposed to repeated mechanical stress. And then the skin breaks down, infection occurs, the ulcer develops. And this is why neuropathy is so dangerous. The problem isn't simply that the foot is numb, it's the problem is the foot loses its warning system. And that's where we become part of the warning system. So when a patient says, my feet don't hurt, so I don't think anything is wrong, that statement should mean the opposite for us. That should mean that the pain alarm system is off, okay? The neuropathy damaged the alarm system. So the patient can have a foreign body, could have a blister, could have a burn, can have a callus, can even have an ulcer, or anything that causes significant damage, okay? And without even experiencing any pain, that would normally force them to stop and seek help. And that is one of the reasons why diabetic foot disease can progress so silently and in catastrophe, what we call, and what I see is limb loss, right? Or amputation. Now, sarconeuropathy. This becomes important, right? Because the patient with significant neuropathy can sustain repetitive trauma on the foot, right? But they can continue walking on it and they cannot adequately perceive the injury, and then the foot becomes warm, swollen, and structurally unstable. But I did a whole episode on this, so I would just try to find it and get into it, okay? Now, what does the stalking pattern really tell us? So imagine your sensory loss begins at the toes. Then it moves slowly upwards and gradually progress higher and higher, right? So proximally. And that pattern is telling us something about the length dependent nature of the neuropathy. Eventually, if the neuropathy becomes sufficiently advanced, the hands do become involved, right? That's stocking and glove loss. But yet again, the pattern is a clinical description, but not a diagnosis itself. So the distribution can be interpreted differently depending on the patient's history and their neurological finding. Now, the autonomic neuropathy and the skin. We already know that plays a huge role in the sweating and the cracking, right? So the autonomic nervous system regulates what we consciously cannot control. So that includes sweating. So if the sweating is impaired, the skin becomes dry. That's why a lot of diabetic skins are significantly dry. And that's why they have actual specific lotion for diabetics, diabetic lotion, okay? Remember, do not put it in between your toes, okay? And that's the reason why cracks in the skin are pretty much become entry points for infection, right? Because in a neuropathic foot, the patient will not feel the cracks, okay? Because you know when you have like cracked lip, especially during the winter time, it hurts. It hurts a lot, right? But so when your podiatrist is looking at your skin, we're not just checking to see if it looks nice, right? We're checking for dryness, fissures, callus, blisters, pressure points, erythema, wounds, and any other signs that the foot is at risk, okay? So in podiatry, we're pretty much detectives. So we're doing a lot of detective work. Podiatrist isn't simply asking, does this patient have an ulcer? Podiatrist is asking, why did this ulcer happen? Is there neuropathy? Is there loss of protective sensation? Is there a deformity? Is there repetitive pressure? Is there a callus? Are they in the appropriate footwear? Do they have peripheral arterial disease? Is there infection? Is there neuropathy? Is there a history of previous ulceration? That is something that you always have to ask patients. Is there a previous amputation? And what can we change today to prevent this from becoming the next problem? Now, that's where offloading becomes such a big key, okay? If a patient cannot feel excessive pressure, mechanical management becomes extremely important. Where is the pressure? Is it underneath the first metatarsal, underneath the fifth metatarsal, underneath the heel, underneath the hallux, the prominent deformity? Is there a particular shoe we can put them in? Is there a particular activity that the patient does? So offloading attempts to reduce repetitive mechanical stress plays a huge role in limb preservation. Okay? Now, when it comes to calluses, I did a whole episode on calluses, okay? Calluses is not just a cosmetic problem. It's a sign of repetitive abnormal mechanical load on that area. So if a patient has neuropathy, they do not feel that pressure that that is creating with the callus, right? And it's telling the clinician that something is happening mechanically underneath that area, okay? You may need to think about the foot structure, the pressure, the footwear, the orthosis, or the offloading and prevention treatment, okay? Now, neuropathy plus vascular disease. That's why we love vascular, okay? So, with diabetic foot that has neuropathy, it can also have peripheral arterial disease. And when you have both, it's kind of a big deal. Okay, so neuropathy can make the injury invisible, but poor perfusion make the healing quite difficult. And when you have both of these problems occur, the risk is extremely greater for the patient. Okay, so why the diabetic foot examination cannot stop at the nerves? That's why we have to evaluate the vascular system. That's why vascular is such a huge part of limb preservation when it comes to a diabetic foot, okay? So the dorsal pedis, our posterior tibialis, the skin changes, the perfusion, the symptoms, that is why we need vascular so much, okay? Now, when does it not look like a typical diabetic neuropathy? Okay, so typical diabetic distal symmetrical polyneuropathy is distal, symmetrical, and length dependent. Okay, but not every neuropathy in a patient who has diabetes is caused by diabetes. That's the whole point of us knowing all this stuff, right? So if you see this rapid progression, marked asymmetry, significant motor weakness, proximal involvement, unusual distribution. It's not stocking and glove. It's atypical, okay? Doesn't mean that they have diabetic peripheral neuropathy. Diabetes does not give you immunity from other neurological diseases. So that is why if this doesn't look typical, they need a neurological assessment. That's why you need to refer patients to the specialist, okay? So, podiatry can help identify neuropathy, can identify loss of protective sensation, identify high risk feet, monitor progression, identify callus, abnormal pressure, address deformity, provide and coordinate offloading, manage appropriate wound care, and evaluate footwear, recognize the signs of infection, identify vascular concerns, recognize charcot neuropathy, educate patients about daily foot inspections, and help prevent the ulcer from happening in the first place. That's why we tell you to look at your feet, okay? But what does a complete neurological exam include, okay? So when we examine the diabetic foot, you can ask, can the patient feel the vibration? You use a tuning fork, 20 hertz tuning fork. Can they detect pressure? You use a 10-gram monofilament appropriate. Can they detect a pinprint? Then you're assessing the small fiber function. Can they distinguish temperature? Again, you're assessing the small fiber function. Can they identify the position of their toe? You're assessing the proprioception. Is the Achilles reflex present or not? You're pretty much learning about the neurological pathway, if it's intact or not. The knee reflex, proximal reflex pathway. Is there weakness? That's why we test the motor functions. We're like, pull my hands this way with your feet, put my hands that way with your feet, right? Is the pattern symmetrical? So think about the distribution. Is it distal? Think of the length dependent neuropathy. Is there deformity? Think of mechanical risk. Is there a callus? Think of repetitive pressure. Is there a pulse present? Think of vascular. Is the skin intact? Think about prevention, okay? So the bigger message of this whole thing is that a diabetic foot examination isn't simply just a foot problem. It's a problem solving problem, okay? So we have to think about neurology, vascular, biomechanics, wound healing, infection, metabolism, and ultimately limb preservation. So when the nerves work, the patient receives warning, right? Pressure, heat, pain, trauma, position. But when neuropathy progresses, those signals become distorted or even disappear. And suddenly the patient is walking on an injured foot without even realizing. So the next time you see a reflex hammer or a tuning fork or a monofilament, don't just simply think of them as tools. I think they're cool. But a reflex hammer is helping us understand the neurological pathway and how it's responding. The tuning fork can help assist and see us detect if the patient has a sense of vibration, right? The monofilament help us detect pressure stimulus and help us see the warning system in that patient. The proprioception says, does the brain know where the foot is? The pinprick helps us see their pain assessment and temperature. And then the temperature one helps us figure out that as well, right? But can this foot still protect itself? That's pretty much the biggest question when we're doing this neurological test. Can this foot be able to protect itself? Because with a diabetic foot, it doesn't always scream when it has trouble, right? Sometimes neuropathy has already taken away the foot's voice, if the foot has a voice, okay? So this is how we learn to listen to the diabetic foot. So this has been Diabetic Foot Files. I hope everybody's having a great Saturday. And I'm Dr. G. Take care of your feet because they take care of you.